So hello everybody, welcome to our research rounds. Nice to have everyone here for the focus today on innovation. Delighted to have a presentation today by Onil Bhattacharyya, who you know is a family physician here at Women's College and also holds the Friggin-Blau chair. So I think it's going to be a really interesting presentation on digital transformation, something I think will be of interest to all of us. And he's also going to be presenting with Jay Shaw. Here's one of our implementation scientists here at Women's College. So delighted to have you both, and I know Laura is here in spirit today. She was on the agenda as well, but she's not going to be here physically today. So welcome and look forward to your presentation.
So thanks everyone for being here. Please file in and find a seat. I would say that the three of us contributed in equal parts to this work. What we're presenting today is kind of two things. One is the accumulation of a couple of years of meeting one Wednesday a month in the afternoon in what we've come to call design meetings to kind of troubleshoot a number of projects that we have going on focused on the adoption of new digital technologies among healthcare teams. So that work has been done with a much bigger team than the three of us listed here, but we've been doing that under Onil's mentorship, and I know we've all learned a lot. And the second thing that that we'll be talking about today is a research paper that we've recently had published in Nature Digital Medicine that kind of presents this weave way, which is about how we might use some implementation science as a touch point, but then really draw on the ideas and methods of service design to think through more effective strategies to promote the adoption of technologies in healthcare. So Laura couldn't be with us today. She's in San Francisco, but Onil and I will be trading off on the talk. So just for disclosures, Onil's received an honorarium and paid travel for some work on the future of patient-doctor interaction. For our outline, so I'll be setting this scene by talking about sort of the diffusion of digital technologies globally. Here that's called digital progress. We'll say a bit about projects being complex, introduce implementation science, and this is an ongoing conversation among the WIHV team about the value of implementation science and thinking with implementation science, so I'll make a few comments about that. And then I'll introduce service design more generally and then hand it over to Onil, who will dig a bit more deeply into value proposition design. This idea, this is a heuristic, tool plus team plus routine. It's intended to direct our attention toward the things that are most relevant at the level of the clinical adopter system for technologies. This was the core idea, the core contribution in that manuscript that we published at Nature Digital Medicine. So Onil will say a bit more about that, provide a worked example, and then conclude with some reflections. So the world is becoming digital, and this is not surprising. In Canada, we have a very digitized lifestyle and a digitized economy, but to see the numbers internationally, and this is very recent, just from last month, where there's over 4 billion active internet users, almost 4 billion unique mobile internet users, almost the same number of active social media users and active mobile social media users. So, the internet is everywhere and it's mobile, and that's leading to this massive proliferation of things that can be done with the internet. Digital technology promises to make healthcare better in many ways. This is something that's been a topic of conversation, technology in healthcare, for a long, long time, decades, 100 years. This quotation comes from a paper co-authored by some researchers, including Ashish Jha at Harvard, and it's simply called "The Digital Transformation of Healthcare: Current Status and the Road Ahead," and that's from 2010. And in 2010, they made this statement: both in the U.S. and globally, the importance of IT in healthcare is expanding as policymakers look to technological developments as a means of making healthcare safer, more affordable, and broadening its reach. And I think these are kind of the low-hanging fruit in terms of the possible impacts of digital technology in healthcare, enhancing safety, enhancing affordability, and then reaching traditionally inaccessible places. There are certainly others, but these are, I think, kind of the holy grail around the potential value of digital technologies, especially as it relates to the triple aim, now quadruple aim of quality goals in healthcare. So confidence in the potential of this digital transformation and the role of digital technology remains high. This is from a group called CBI Insights, which tracks markets internationally, digital technology investment, and also they have a specific research group that focuses on investments in mobile health. And the years here are from 2010 to 2015, but the point is to show the clear and continued increase in venture capital funding for mobile health companies. So from the economic side, clearly confidence remains high. But adoption remains challenging. And this quotation here is from a research paper from the American Journal of Managed Care, and they publish an e-health issue every 2 years. So from 2018's version, one of the papers from a researcher, Juliet Rumble-Smith, who spent some time here at the University of Toronto, her group found that, so they were looking at electronic health record usage, so super users and under users in ambulatory care. They found that 73% of practices were not using electronic health records to their full capability. Nearly 40% were classified as under users. And then they could say a little bit more about those practices. So under user practices were more likely to be of smaller size, situated in the West, and located outside of a metropolitan area. So we're starting to understand a bit more of kind of the epidemiology of the lack of usage or the degree of diffusion of these technologies in healthcare. So adoption remains challenging, and hence a service design approach. Now, this image will appear again later in the talk, and I'll elaborate on it a bit more. But the key point is that this is a different way of thinking about it, and so I'll continue on to talk a bit more about that. This is a screen grab of the paper that we had published. So the title is Beyond Implementation: Digital Health Innovation and Service Design. So you can see that what we're trying to do here is maybe challenge what I have come to understand as a linear model of implementation. And in some conversations I've had with Onil and at the design meetings, maybe I'm a little bit too hard on this idea of a linear model of implementation. But we'll flesh out this idea a little bit more, and then maybe we could have some discussion about it as well. So the context for writing this paper is that implementation isn't working. Maybe that's a bit of an overstatement, but when we look at the resources devoted to promoting the development of new technologies and change management in healthcare organizations, we don't see the commensurate uptake for the effort and resources put into that work. So the question is why, and this has it became the fundamental premise of our paper, that there's been insufficient attention to the relationships between digital innovations, or the tools, the technologies, and the service innovations they require. So the idea here is that, and this is now a fundamental insight that is a part of all of our work with teams who are looking to adopt digital technologies, that when you're doing a project that's intended to evaluate a digital technology, you're not evaluating a digital technology, you're evaluating a service that happens to be technology enabled. And so this brings our attention away from the digital tool itself to the configuration of the service that may need to change, that is evolving in some way as a result of the adoption of this technology. So we've used this idea of value proposition design, which Onil again will say a bit more about. But fundamentally here, this is about being brutally honest about the value of a new technology for each individual involved. And there are many ways to sink a ship, and it's the same with these complex projects. It doesn't take many people to not be interested or to not want to engage, or to in fact have a negative approach to an entire project in order for it to not get off the ground in the first place. So I'll say a bit more about this image now, and again, this is about, I believe this is about thinking about the implementation process in a different way, because it's not necessarily simply about the uptake of a best practice, it's about thinking about the entire configuration of services. So this articulates at the highest level like a methodology for service design. So the first step is to empathize, and this links back to this previous point about value. Really empathize, like really be brutally honest. What is the nature of the experience of the people who you're working with? If it's busy clinicians who you're expecting to adopt a new technology, really try to empathize, put yourself in their mindset, feel what they're feeling. How difficult is it? What are their hopes and dreams, and how does this technology relate to that, maybe interfere with that? The same goes for a patient who you're expecting to use some kind of mobile application or self-management. Is self-management even something that they care about? This is where being brutally honest and really empathizing is really important. The next step is to define, and I think that in our experience over the past couple of years of using service design approaches, this is what I've found to be most challenging, actually, is taking those feelings and those ideas that come from the first phase around empathizing and put them into words. Start to articulate in words what is the value of a new technology, what are the jobs that people need to do, and how does this relate to those jobs? So this is something that, again, we'll talk more about, but it is a very important part of the service design process, bringing those thoughts and feelings into words so that a team of people can work with them. Third is to ideate. So this is coming up with what the new configuration of services of the service will look like. Next is to prototype. So this is hammering out workflows and understanding how this new configuration of services will interact with people's everyday work. And then the last step, of course, is to test it out. And this is something that comes up again and again in service design work, is just try it out. You got a new technology, just put it in people's hands and see what happens. There's lots of learning that happens in these small tests of change, very small. And that can be used to feed back into this cycle and better refine our definitions and our understanding of the problems that we're working with in the first place. So projects are complex. This is something that I think all researchers know intuitively. This is a screenshot of the partners who are collaborating on WIHV's Center of Excellence in Digital Health Evaluation. There are many, and they range from healthcare provider partners to digital health companies to intermediaries like Mars to evaluators to policy partners, etc. This begins to articulate, the wide variety of interests and routines that are involved in digital health adoption. Here we have a screenshot of Trish Greenhalgh's, this is a framework on the non-adoption, adoption, sustainability, scale, and spread of technologies in healthcare. This paper describes this model and how these things all fit together. But if you look at the sort of list of issues to be considered, it's extensive. These things are complex. So now if we look at implementation science and the approach taken by much implementation science to deal with this issue of adoption, I think this original definition of implementation science from the founding issue of the journal by that name, it provides good insight. So Martin Eccles and Mittman, they define implementation science as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence, to improve the quality and effectiveness of health services. So implementation science, I think is a really important field, and it's brought evidence-based medicine and evidence-based practice into a new era, an era where people can't just be expected to take up research evidence and other best practices. They need some help. So evidence-based or implementation science, I think, has done a lot of good to help raise awareness that we need to put our resources and actually do research about the processes by which that's best achieved. I do think, though, and this is a bit of a caricature of implementation science, that it's approached that challenge in overly linear ways. I think the idea of a systematic uptake of evidence-based practices, just the language used, suggests to me that the primary goal is just to get a best practice used, with a secondary goal of improving quality and effectiveness. So if I contrast that to service design, I think of service design as iterative. I think of the unit of analysis as being the configuration of services, not the uptake of a technology. So I think these are slightly different logics around promoting the adoption of innovations, but this is, of course, an open point for discussion and debate. This is perhaps the most famous framework from implementation science, called the Consolidated Framework for Implementation Research. I think it's fairly typical. I love to show this image because I think it's pretty ugly, but comprehensive at the same time. So it outlines the issues involved, the units that need attention when doing an implementation project. Individuals involved, the inner setting, which is kind of like the organization, the outer setting, which is like the kind of policy or the external environment, the nature of the intervention, which has core components and an adaptable periphery. So there are some things that can't be let go or can't be changed, but then there are other things that can be in the context of an intervention. And then there's a process that needs to be considered. And I would say that this process is probably the most important thing. And that's where there's been less has been said in implementation science about actual ways into that process. What is the nature of that process? What should you actually do when you're working with teams? I think that there's been less said about that in implementation science. And that's what motivates our turn to service design, is about finding a way into that complexity and starting to understand that process a bit as we are doing the work with teams to promote the adoption of these innovations. So I'm not going to read all the stuff on this slide, but I am going to walk through each of these points in detail. This is an overview of service design from an academic journal called Design Management Review. And this is a highly cited kind of portrait of service design as a field. So we'll talk about the first one. So what is service design? It aims to create services that are useful, usable, desirable, efficient, and effective. I think in healthcare, we tend to think of services as necessary, as opposed to as something like desirable. But this is this thing about being brutally honest about the value of an innovation for people who are doing their work or living their lives. You know, when you walk into a restaurant, you just know. Or when you see branding, you just know when something appears nice, when you're attracted to it, when you want to associate yourself with it. And this is a thought process that I think it's difficult to arrive at in healthcare, just because of how healthcare is set up and the way we're socialized to think about it. So this is one of the ways in which service design offers a unique perspective. Second, focuses on customer experience and the quality of the service encounter. I think healthcare is coming around to this idea with patient engagement and patient and public involvement. But service design tells us that there are many dimensions to user experience. We need to start to peel back layers about what the idea of user experience is, what a customer experience actually is. So this is another way in which, although healthcare has begun to look toward experience as an important input into innovation processes, service design, I think, does that in a much more sophisticated way. Third, service design considers strategic, system, process, and touchpoint design decisions. So this is about, the work of service design happens with people, but those people are attached to other institutions and other goals that exist outside of the room that the meeting is taking place in. So, if there's directors, senior leaders from an organization, they're responsible for a strategy. If there are people who are representing procurement, they need to know about policy, things that are happening external. So this kind of framework is from a book written by Kim Vincente at the Global Center for eHealth Innovation way back in 2003. And he articulated these various, the location of human factors in understanding the impact of a technology on an organization or on a process. So of course there's physical, there's psychological, there's team, organizational, and political. These influences need to be considered at each of these levels, and that's something that service design encourages. And then the last point is that service design integrates a user-oriented, interdisciplinary, and iterative approach. So this, just put it in people's hands, learn something quickly, you'll ideate better, you'll define better, and you'll have a better iteration in the next round. So for us, figuring out a way to incorporate this process in a brief period, 2 to 6 weeks at the start of our projects, has been a challenge, but also, I think, a big success. It's something that's really driven a lot of the insights that we've been able to offer to the people that we work with. So this is just the last slide I'll comment on. This introduces value proposition design, and I think the most important thing here with this idea is that it flips the idea of value on its head. As researchers and healthcare providers, we tend to try to dominate this idea of value. We know what the evidence says. We know what's best because we study what's best. But for the sake of adoption, this approach says don't think about what we consider to be good value. Instead, think about the people who actually need to use the technology. And this is part of being brutally honest. So I'll pass it over to Onil to continue.
Okay. So one of the ideas in value proposition design is this shift potentially between a problem pull, identify a problem, and then see how might we better address that problem, and solution push. So a lot of the tech world is about pushing solutions out there, and this idea of a problem looking for a solution, or solution looking for a problem, is often a criticism. But given the massive range of solutions that are out there, particularly in the tech world, you can't rebuild something for every problem. There's so much already out there that sort of adapting it and figuring out what it's good for is, I think, a useful place to put your energy. So the first step in value proposition design is really thinking about what are the jobs to be done? What are people trying to do in the context of a particular, say, patient encounter? As a primary care physician, patient comes in, I'm really thinking about, I've got, 6 or 10, 15-minute encounters. I need to get to the end of it. I need to identify a problem, solve that problem, wrap it up, and move on to the next case. So in a lot of our thinking, anything that slows down my job of getting through my patient list is something that's not adding value. And so that framing is really important when we think about uptake. Steps in there might be calling up the notes, getting important information from the patient, getting an oral history, looking up a drug dose, and then printing out a prescription. So that's sort of the job from the doctor's perspective, and then, different users will have different perspectives there. So when we think of that early phase, we're really thinking about, you've got the jobs, but you're thinking about your pains, gains, and the jobs you want to get done. So I'm going to take one example of a technology. The picture appears later. But we have a series of these projects called the Health Technology Fund grants. We have 5 of them in the field. We have 9 under review. So we're doing a lot of these, and they have $150,000 budgets and 2-year time frames. So they have to go fairly quickly. And this is a technology being implemented for the first time in a new clinical setting. So one particular one is something called Cloud DX. It's a tablet that for patients with COPD that measures your O2 saturation, your blood pressure. Has a bunch of wireless devices that communicate with the patient. And so when we first presented this, we had a big meeting with folks at Markham Stouffville Hospital, and we said, here's the tablet. The tech vendor was there. We had folks from the Ontario Centre of Excellence that are the funders, and we had a series of administrators and people from different departments. So we said, here's this awesome thing. It can track all these parameters at home. It's a great tool for remote monitoring. And so we said, this will be really great for your patients with COPD that keep bouncing back to the hospital. So in primary care, so that we went around the table, and the guy from primary care said, well, we don't do remote monitoring. We don't track patients at home. We're not even there in the evening. So why would we use this, right? Another group said, well, who's going to collect this information? Doesn't this introduce some liability? What happens if something bad is happening and no one answers it? So it wasn't clear from a lot of the people in the room that it was solving a problem for them. One group, as an example, was from ENT. And they said, we're trying to send patients home for same-day tonsillectomies. But we don't know what's going on with them at home, or we're not even sure which ones to send home. This would be a great technology for us to use. But since the project was owned by the respirologist, they said, that's cute, but that's out of scope. So it was interesting that we were struggling a little bit initially to find a value proposition on the provider side. For patients, and this is where we started, Jay said, you got to just take these things and put them in people's hands. So we got 10 tablets, we gave them to a bunch of patients. And so the things they said were, well, what I don't like is, it's hard for me to get to a clinic. It's hard for me to get a hold of someone when I'm worried. If I have a tool that says, tracks changes and allows me to get in touch, or people to get in touch with me when I have a problem, that's going to reassure me. And caregivers also feel reassured when they have access to that information. So there was a series of sort of pains around nervousness, around your own condition, around your loved one, that we thought we might address. In terms of gains, well, if you get answers faster, if you don't have to go to the hospital, those were also gains that people articulated as being beneficial. So those are the first two things. And when we generate these pains and gains, what's really important is to figure out not just what's the shopping list, but what are the essential ones? What are the ones that are going to make people decide to adopt something? The next step is so we're looking at pains and gains. Now we're thinking about what's the service we're trying to provide. So for this, you need to understand what makes up a healthcare provider's daily work. In the example of this remote monitoring tool for COPD, it turns out that nobody really does that job. At least a respirologist doesn't do that job, but they had respiratory therapists that kind of track patients, that take phone calls, and they are the ones who actually have the bandwidth to follow up, to see what's coming in, because people have these tablets at home, they're sending data on their oxygen and so forth in, and as well as symptom scores. So a respiratory therapist who takes phone calls from worried patients, this tool could be incorporated into their workflow. So that was one area. So we're trying to understand the jobs for the respiratory therapist and explain how the technology might resolve those particular pains they had and explore how it might provide new gains. So from the respiratory therapist perspective, you could manage more patients and keep track of the ones you're worried about more easily. But interestingly, for the respirologists, it didn't solve any problems for them. So they said, as long as somebody else is filtering it and coming to me, I'm happy. But they didn't really want to have any direct connection with the technology. And this is actually a recurring thing that we're seeing, is that people might see some benefit for someone else, but don't actually want to be using it directly. The next step, so you've identified pains and gains, you've thought about what you're offering and how that might relieve some of those pains. The next is going through the values. So these are the different value propositions. Time saving for patients were obvious, convenience were obvious, reassurance were obvious. For the respiratory therapist, we had a couple of those things, a comprehensive understanding. I think for the rest of the RT, they manage a panel. So they have a panel of patients, and so they think in terms of not individual encounters, but in terms of populations. So that was another area of value. And so we sort of start mapping these exercises, and as you put the technology in front of people, they start to say, oh, this is useful, this is not, and they can start to rank things that would affect their behavior. So the next question is, how does this fit into the broader context, right? Right now we've talked about specific users and how they view things, and I'll just say to a minute more about value, is if you think about it, in our health technology fund projects, we have a technology vendor, we have a provider, we have an institution, and a payer. And when you map all the value propositions, they don't align, and a patient, and a caregiver. So when you take those 6 people, the value propositions don't align that often. And so you're going to have to choose a subset of them and say, okay, these are the ones we're going for. Once you've established a value proposition, then you say, okay, what does it look like in a clinical setting? And the sort of heuristic that Jay mentioned is something we're using to think, if you think of Trish Greenhall's crazy complex framework, it's like, what are the few things I can get my head around to communicate this and work on? So these are tool, team, and routine. And so the first question is, does the tool have a clearly stated value proposition for all involved? Not a trivial question, right? What are the subset of value props that align the right set of people to move the thing forward? And just as an example, when we talked about that CloudEX, that platform, one example was the hospital being concerned about liability. And they were saying, well, we would like this to be a tool for self-management for patients. They get feedback, they adjust their medication, they use their action plan. It's self-management, it's got nothing to do with us. But then that puts an onus on the tech company to have some kind of decision support software that might require a different level of Health Canada approval, and that introduces liability for them. So often value props are in tension, right? It turns out in this particular study, we decided to do a randomized trial comparing self-monitoring versus remote monitoring by a respiratory therapist. So when we think about the tool, that's the first thing, the value proposition. The second is the team. Will relationships be strained, newly developed, or need to change? In our case, with this respiratory therapist, we actually had to hire a new respiratory therapist who joined the clinic because the team, as configured, wasn't able to adopt this technology because it was doing tasks that nobody was doing before. And the last is the routine. How do existing work routines need to change? So these are kind of how we approach any setting. You've got an existing team and routine. You introduce a technology. It has a value proposition for all, at least, or a subset. And then you start iterating on this. So when you start your intervention, you're trying to think about what is the right team, what are the right members, who's doing what is the right tool. And now this tool, you can iterate on the tool. You can go back to the tech vendor and say, we need a different function, right? So their tool for COPD had O2 set, had a bunch of physiological parameters. It didn't have symptom scores. But as Aman and others can tell us, symptom scores are what we use to identify exacerbations of chronic obstructive pulmonary disease. It wasn't even built in. So we say, you need to change the tool to achieve our goals. And then what is the routine? In the course of the project, it turns out that this has been a ton of work for the respiratory therapist. We thought it'd be easy. It turns out it's not. And as a routine, the trial as configured will not become a routine. It's going to have to be stripped down, and that's an ongoing process. So this process of iteration is really a recognition that technologies, we haven't compiled the stats, so this is an exercise I want us to do, is look at how often is a technology implemented in a clinical setting, how often is it taken up in a meaningful way, how often does it show value, and how often is it procured? Because in these grants, that's what we're trying to do, is inform procurement decisions, and I'm guessing it's probably 5%. Get to the bottom of that, right? So we are dealing with enormous levels of uncertainty, which require us to change our mind pretty often. In this tool team routine exercise, one of the biggest challenges has been to get this wide range of stakeholders to agree on stuff. And when we're getting a signal that things are not going in the right direction, how do we get them to change their minds? And that has not been easy. Many people have vested interests. Everyone wants to declare this is a success. But we come in thinking it's only got a 5% chance of achieving the goal we set out at the beginning. So if we don't change course along the way, we're going to be in trouble. So so that's sort of some general thoughts on service design. Now I want to situate this, and here's the example that I talked about of work in a community hospital. This is the Cloud DX platform and all the stuff it does, and the tools around it. So I want to close with a sort of bigger conversation around stages of service development. So if we think of, on one extreme, generating and eliminating options, and another extreme, generalizable knowledge about causality and impact, where do these things sit, right? So if Women's College Hospital says by 2020 we want 25% of our care to be virtual, that's a solution push approach, right? Virtual care is something good. We want to put it out there. We want to do more of it. But we actually don't know what it's good for. So we will have to generate and eliminate a bunch of options. So we're doing virtual care projects in dermatology for looking at ulcers. We're doing a thing in primary care with virtual visits. And Haley's heading up a project in GI using video visits. To do this service design work well, we would have to generate like 30 options and test them, and maybe pitch it to different clinical departments, see what they think, see who's interested, test out a couple things, see if patients are interested, and maybe, looking at tool team routine, generate and scrap options every 2 weeks, and maybe eliminate, of the 100 potential ones, eliminate 95 of them and go with 5, right? So if we think about what is the level of oversight required for that? Over here, we are talking about research whose goal is to create generalizable knowledge, but also advance the careers of researchers who can publish grants, publish papers, and get grants. And there's a lot of oversight, right? You've got a research ethics board to protect patients and providers from the undue burden of that activity. over here, if we're an institution that says we believe in modern managerial approaches and service development, and we recognize that most of what we propose is not going to work, what is the oversight required to generate and test 50 approaches to virtual care in the next 3 months or in the next year? Is this a frivolous activity from which we need to protect patients and providers through a rigorous oversight from a research ethics board, or is it a managerial responsibility for an institution that needs to be rigorous about how it evaluates the work it does and how it generates and scraps options, and what kind of oversight is required? So I want to just put it out there that I think that service design, quality improvement, and research require 3 types of oversight. And as Bailey others can attest, we set out how many years ago now, Bailey? 5 years ago, to set up a process that we now call APQIP, and Noah was intimately involved initially, was to say, okay, let's make the low-risk research easier to do, let's make quality improvement research easier to get in the field, and we ended up creating something that is super laborious and has made our work in quality improvement and service design actually very challenging. So I want to sort of stop here for a minute and open up the conversation to think about how do we develop better services here at Women's, how do we achieve the goals set out in the strat plan of virtual care, and how do we achieve the promise of digital tools to transform healthcare. Thank you.